will be the correct pressure for the bladder and the rectum. That is what we expect. But this is not connected. Second way of zeroing would be that that is correct. Now, second way of zeroing is that these cubes, these are are now connected to the transducer. All right. So are they correct transducer? Yeah, transducer connected. No? But corrected. Now zero. Now let us see if the machine shows zero. Can you see the machine?
So they are actually
one way of knowing the machine.
We can't see the screen.
I raise the screen.
Dr. Shirish, we can't see the screen.
Raising the tube, there will be equal displacement of the pressure. Is it equal? Not. 2649. Now this is not correct. It has to be done. There has to be, yeah. Flush color. This it gives to be flush properly. And this is the best way of doing it because it also allows you to make sure that there are no air bubbles and
cameraman, please focus on the flushing.
The tubes are properly primed.
Guide the cameraman, right?
Other one? Yes, Guru.
Focus, please.
All right. Very good. Now they eliminated all the air from the system, bringing it back to it and making it zero again. All right. Now, if the machine is recording correctly, I must get equal deflection on those. And it seems to be good. Look at that. 62, 63, 64, 65, equal deflection. So the machine is properly primed. Okay? And even subtraction is good because the tube is showing either 0 or 1. And do you appreciate that? Can everybody appreciate that?
Yes.
Now the system is properly primed. Now this system should be connected directly to the tube as it is. Correct. अभी देखो कौन सा channel कौन सा है? Now this is the rectum. Rectum.
Sir, do you ensure that the bladder is empty?
Okay.
Yes, sir.
Yes.
Do you ensure that the bladder is empty?
Yeah, bladder is empty.
Yeah, but we should ensure that it is empty, no?
That is completely empty. There is one more thought that a neurogenic dysfunction is not empty the bladder, but it will not add to complication of understanding. But there is one thought that don't empty the bladder and fill up on whatever the physiological volume is. Not pathological. Okay. It is a rectal view, connected to the rectum, very good. Now put a this will be connected for a flush column. Flow back a little bit. Like your nose is funny. Don't go straight. It just flow back by pressure. Right? That means there is no air in the system. And now I'm saying. So that's second way of zeroing. And I prefer that way because it allowed us to make sure that transducer, when we raise these tips, the pressure deflection is equal as well as correct. And then you have a good confirmation that the subtraction is good. And then you connect it to the fluid-filled catheter so that there is no air in the system. And that's the pressure of 5 and -5. Which is not very agreeable. So we just first one thing, rectal no flush column. Rectal में यहाँ पे कर. So ये rectal है ना? And we show you that. That seems to be good. So 5 and 0 or something like that. So we expect some pressure. It can't be 0. It's close to 0. Expect some pressure. So the empty the bladder, resting pressure is to 5 centimeters. The rectum pressure is 0. And we will now issue either cos. इसका नाम क्या है? जोया. क्या थोड़ा खांसी करो बेटा. खांसी करो. जोर से खांसी करो. जोर से करो. जोर से खांसी करो. करो. Okay, if she cannot do that, I can give a sharp pressure on the.
You can let us see the monitor, cameraman monitor.
All right, it's showing correct now.
It shows that.
Yeah, concentrate, focus on the screen and
focus on the screen. You should see the curve, right?
The reflection.
Yes.
So I think this is acceptable situation. We can start the film. Right. So we have not discussed the two ways of viewing. One is keep the transducer open to the atmosphere. Bring them to the synthesis tube and they connect all the tubes. Second is you have connected the tubes, you have primed the tubes with saline, eliminated all their bubbles and confirmed that they are showing the correct deflection and equal deflection. And then you have connected to the line, the rectal line and the intravaginal line. That's number 2. And number 3, of course, is the tubes can be brought, those tubes can be. Those tubes can be brought to the level of the wrist, this and 0 to the atmosphere. Atmospheric pressure is just a word. I don't want you to try to get into complexity of atmospheric. Any pressure that we measure is always above atmosphere. The pressure in the sphygmomanometer is above atmosphere. The pressure in the tire of a car is also above atmosphere. So really speaking, all the pressure have to be above atmosphere. We don't go below atmosphere any time in our daily life. Okay, so that's it. And when I give a sharp pressure on the bladder, it shows almost equal deflection, and that's perfectly acceptable situation. Now we are going to start the infusion. We start with a very tiny rate, about 15 ml per minute. Yeah, filling. Yeah. Yeah, देखो कुछ पानी अंदर डालोगे थोड़ा. हाँ, फिर ले लो. And अगर कुछ लगता है ना पेशाब जैसा तो हमें बताना. ओके, बताएगी ना? हम पूछेंगे, लेकिन बिना पूछे भी आप तुम बता सकती हो. ठीक है? Alright. So we start the pump, please. Noted. शुरू क्या? हाँ, क्या है ना? इसे क्या ऐसा क्या दिखा रहा है? शुरू किया ना आपने? नहीं, इतना शेयर. अब शुरू करो ना. ठीक है? अच्छा रिकॉर्डिंग ना. ओके. इतना फर्स्ट है. All right, the pressure recording is perfect. All fine. That's pretty good. I think it's better. Can you all see the? Can you concentrate? Can you focus on this? थोड़ा sharp pressure देके दिखाओ मुझे एक बार. Sharp pressure just about the period. ठीक है ना? स्पीड थोड़ा
completely guidance from the yes, thank you.
Okay. Can you see the screen now?
Yes, better.
Okay. 3 and 0, 4 and 0, and subtraction is perfect. That's perfect. Yes. So now Sahej is giving a sharp pressure and suprapedical. Sharp, just quickly come and go. Yeah. Correct. I mean, that is not showing us a good deflection for some reason. Yeah. This is what I mean by quality urodynamics. Because नहीं हो रहा है तो कुछ न कुछ प्रॉब्लम है. थोड़ा ट्यूब फ्लश करो रेक्टल की. I think what has happened is rectal catheter is too large and it requires a larger volume of fluid displacement to show the correct pressure. बस बंद करो. ओके, अभी अभी शॉर्ट प्रेशर दे दो साइड। That's better. Okay. Again, it shows the line. I don't know why it goes. We may have to change the rest of the line. Intravertical question, I have no problem. The vertical question is not making much any sense, but this is not acceptable. छोटा लाइन है क्या आपके पास? You got another balloon क्या कहते हो? है? आप भरते हैं? तो भर के दिखाओ। मैंने कट किया था। नहीं, भरा नहीं, चेंज करना था। फिर कंटिन्यू हो रहा था, फिर चेंज करते हुए मिलता है। चलो कितना स्पीड है? 50 मिनट्स। चलो we will, there won't be change for the topic because you know what the thing is, we have got two different parts. One is a small catheter with a cup on the top of it, and other is a balloon catheter. So balloon catheter, I feel, is not accurate because the pressures are measured along with the rectal pressure, and then we should be difficult to determine which is the rectal pressure which the balloon. But anyway, that is very useful. So use such standard balloon catheter. Very large catheter section, and that's why I think we should resume to the usual practice here. Okay, what's important here is that the bladder pressure shows a steady increase. So is the correct bladder pressure or is there a component of other surgery? You have Bond's marker height. अगर Bond marker हो तो pause करो. Plus 12. Done yet? No. Okay, but the pressure part, yeah. Yeah, I think the category is blocked. No, yes. It is showing a very high pressure. Hey, okay. Show it again. You know, close down. Oh, no, but.
Show us the monitor, please.
कितना दिखा रहा है प्रेशर अभी?
Camera में monitor, please.
Pressure में? Yeah. कितना pressure? No, it is not measuring. You take that 8 French Urodynamic, let me tell you. आप हमेशा कौन से यूज करते हैं? फ्रेंच की चैनल फाइन की जगह थोड़ा बड़ा चाहिए, नहीं सिक्स एट नहीं है और उस पर ना आप Shivam, are you there?
Yeah, we are with you.
Basically, you find that so rectal pressure measurement is not coming to our satisfaction. So I think we'll have to go back to our Guru technique of trying to stop. You have a hospital. Very simple. Right. इसको थोड़ा कट करना
एक बार कोई ट्यूब में क्लिक तो नहीं है। Is there any click on the tube?
Another problem could be the another is very bad when the pressure leaks out. And therefore it doesn't measure. It must be inserted into the computer of the factory. But it is a it's very error. इसके बाद में
In the ward there, we can have future.
मतलब कुछ भी रह लो ठीक हो गया है control it's very in the right what can no, I will answer. Here is some jewelry. Yeah, but if I can't get on. No, it's not doing correctly. Yeah, it's still a funny another parent. Flush the water. In such a way that enters the ampulla is a lack of no, थोड़ा फ्लश करके कनेक्ट करो Now, click here. This is correct. ठीक है ये बराबर नहीं कर रहा है the transistor is not working. Okay. थोड़ा फ्रेश करो इसको not getting why the dropping now let us see now yeah okay 4 5 1 let me see Shivam, as you can see, I'm still not satisfied with this. Now, all we can do is to bring a small little there is a leakage of pressure. You can take a focus here. Yeah. This is something you all should understand also. With the leakage of pressure. So we should have a exactly equal deflection, then we cannot start the study. But there is no equal deflection. So some pressure is leaking out of the rectum. So what I'm trying to do, close enough. What I'm trying to do is to pack the rectum from outside so that there is no leakage of air by the side. See that one. We normally use some kind of a pyramid-like connection. We show you the next one. Here it is here. What I need to do? Put this into so these fresh impact is one. Again, let us see. Still not there. Can you see the movie? Yes. Flush करो, flush क्या कर रहे हो? Focus, focus. दोनों flush करें. Very good, very good.
बोलते थे पक्को तो
we have the company people also with us and me.
Okay, yeah. Accept it now. But again, give me this finish with the question. I'll give myself one thing. If you buy it, yeah. See, there are air bubbles in the system still. You have to give one more finish. You must get rid of air bubbles over there. Pressure measurement is okay. Unless you get correct pressure line, we cannot expect a good urodynamic study. All right. And that's the pressure setting up. Now I'm going to do. Not completely all right, as you can see, we are not satisfied with the pressure measurement. I think something wrong with the kind of calculus it's using. I have no problem with the intravesical pressure. The rectal pressure is not measuring correctly. Yeah. Let's start the reading. This should not happen. That is when I properly up जो करते हैं तो बराबर होता है recording. तो अभी करके देखो ना.
हाँ, देखना we have the technician, we have the company people also.
अब पता है ना, अब करते हैं ना. तो ठीक है, क्या प्रॉब्लम है बताइए. ये क्या कर रहे हैं आप? Let him do it because he's using this machine. Yeah.
देखना जी कहीं किंक वगैरह तो नहीं है, देख लीजिएगा. ट्यूबिंग्स में किंक नहीं है, कुछ भी देख लेता है.
So he is emptying the bladder now. But realistically, I think that the struggle is with the rectal sexual relationship.
Is it because the bladder is not being emptied or private? Well,
We already infused some amount into the bladder.
okay. So we have a bladder scanner also. That's yes.
Any questions in the meantime? Let alone the
Yeah.
technique, but really, yeah, so technique.
Anybody has any questions?
What are the aims of,
No,
managing the bladder in patients with myeloma?
I mean, it's quite. Yes,
What are we have to ask for urodynamic questions, no? So what are our questions and what are our aims of management?
We discussed the questions, Sujata, but
And they discuss that, okay.
So in the meantime, they are doing, Dr. Shri,
yeah,
what do you think these patients, how do they fare as they grow up? And what do you think needs to be done in these such patients?
no, we just have to get the life correct. Usually must be correct. All rare must be eliminated.
No, I'm not asking about the urodynamics. I'm asking about the patient. How do they actually, how they need monitoring and how do they actually in later life, what type of kind of management they do require?
After this.
After this, because she has been operated on many
Yeah,
times.
it's still what we find in Urodynamics. So, we don't know whether her bladder is bad enough to damage the upper tract in the future, and it may well be. And then we either have to give her an aggressive therapy to reduce the bladder pressure, and give her.
So what do you give to release the bladder pressure?
Yeah, we will certainly use the drugs in the first place. We will use polyphenol.
Okay.
Background.
Yeah.
See how it works. It could well be a case of botulinum toxin, but it won't do that as quickly.
Right.
We may be able to get away with just adjusting the interval between the catheterization. If we can say how much volume is required to produce dangerous bladder pressure. And then we aim for bladder pressure in lower than 25 centimeters. So what is the volume required to get the bladder pressure? And can we increase the volume by drugs? Sometimes you can do that. You can see
So in children, you would prefer observation, right?
Well, I think at this age group, I don't mind using polyphenol because oxybutynin in younger children, yes, but I think oxybutynin has not shown to have any more side effects. So oxybutynin is getting less and less is popular. But yes, at this age is 10, but she's not a very young child. So I don't mind using polyphenol.
All right.
2.5, 5 milligram, 2.5 in the morning, 5 milligrams.
So what will be your threshold of pressure which will be detrimental?
We'll try and keep it below 25 at all costs.
25. Okay.
This is difficult.
So in a female patient, 25, and a male patient also the same?
Both.
Both.
Yeah.
Okay.
Below 25. That's good. Not this good. I don't believe in 40 at all. 40 stages. But in 25, but it will be less good. The target should be 20 centimeters. And try and get a catheter before she reaches that pressure. That is something we'll have to work out with the intake and volume voided and so on. But that can be worked on. She's Her mother is doing catheter, she's doing it very efficiently. Doing it as a child is not that easy. Apparently, she's doing it very well. So I think she can rely upon it with respect, which will be the good posture, right?
So besides pressure, if suppose, what else would lead you to do some kind of invasive treatment? Yes.
Which can be applied. Please something now. The catheter was very good. Right?
Right.
Yeah, that looks pretty good.
Okay, that's good.
See now, this is the point. If the technician knows it much better, he's doing it every day.
Right. So cameraman, please focus. Lake right.
Yeah. Thank you so much. Very good. So let's start the recording now. Okay, let's continue the discussion, Shivam.
Yeah. So now you think it's pretty good, right?
Yeah. So it is the same catheter,
Yeah.
usual loose catheter, and the large rectal catheter. And the same thing. The thing is changed, except that this time touch can be something.
So we are doing infusing it at 15 ml per minute. Yes.
Yeah. Patients are negative, which is not right. Yeah. Why the patient is negative? Will indicate it right again. It is not calculated. Okay, zero. Yeah. Yeah. All right. Perfect. अभी अभी क्या है अभी ये जो प्रेशर है ना दिस प्रेशर इज टू मच शर्मा जी ठीक है एक बार रिलीज करो यार गश विल कम आउट यस ये बात है ना ये संभव
Okay. Yeah. Yes. So yes, Dr. said.
ये जीरो करना ठीक नहीं है आप ऐसे करते हैं क्या शुरू once you are connected you are not supposed to touch the zero button अच्छा लगता है देखने में क्या लेकिन let's start
Right.
चलेगा 20 ml करो 20 ml 20 कर सकते we don't have a diary about the body, how much she works, how much she. See, what happens is invariably, Shivam, are you listening?
Yes, yes.
There is always a temptation of using the zero button after the tubes are connected, and this is the biggest mistake because then you are cheating the machine. You are telling them that this is zero. No, but the machine has to be given the correct information. All right. So you should never touch the zero button after connecting them. Okay. Or when all the tubes are connected properly, okay, then you can't say zero. Zero has to be done before that. But for obvious reasons. Now, I hope everybody in the audience understands the importance of this. The zero button will never be touched after tubes are connected. They must be done before the tubes are connected. Do whatever you like. Transducer to zero and then connect it. Now we see whether the deflection becomes good and quickly in front of the I think it's a little bit low.
Okay. Yeah. That's okay.
Where कुछ लग रहा है बेटा? कुछ नहीं? वो नहीं है क्या? नहीं है?
Focus. Yes.
आपको उसके बगैर में जाना है तो जा सकती है आप रहेगी नहीं है वो दोनों लगती है वो दस्ता की है ना कुछ लग रहा है This the important thing is to be interactive with the patient continuously within the care stage and sometimes you may not come up to answer particularly student So we just have to look at their faces and find out what is happening. आपको लग रहा है पेशाब? नहीं. ये दर्द हुई है? क्या हो रहा है? कुछ नहीं. सिर्फ डर लग रही है. इतने लोग that looks all right. So there is a steady rise in the pressure or the pushulam.
Yeah. We are not getting the video, just a video.
Sorry?
The cameraman, yeah. Please.
Let's concentrate, let's focus on the screen now. How much is the volume now? So how did I sorry, increase volume?
Focus, please.
50, ना? Yeah, that's not much. I mean, yeah.
Focus करिए कैमरामैन.
आपने कभी चार्ट रखा है कितना पेशाब आता है जब कैथेटर डालती है?
Yeah, better.
अच्छा? So that's quite a lot. थोड़ा बढ़ा सकते हैं 25 करें? तो 36 है. आपने कभी चार्ट रखा है कितने बजे रखा कितना हुआ कितना पेशाब आता? लेकिन वो बताती है कब करना है. क्या बताती है? ये क्या बताती है? क्या लगता है? क्या लगता है आपको पेशाब अब कैथेटर का टाइम आ गया आपको क्या लगता है? मम्मी को क्या बताती है? हाँ बोलो ना क्या बताती है?
सहज तुम बात पूछे बेटा.
पेशाब की भावना okay. Some bladder sensation, but as you can see, there is a steady rise in the uterine pressure. It's 22 now. So and increased volume so far is 78, not much. So you can say this is a hypocompliant uterus, and that may give you the answers to a number of questions. Number one, is this an unsafe bladder for the upper tract? Number one, and number two, is this the cause of an incontinence? So both the things may be involved in this answer. Is steady rise in the uterine pressure in response to rising volume could lead to incontinence because right? Yeah, just put around first sensation. And first sensation is not a sensation of urination. First sensation is a sensation that something goes into the bladder. It's just a perception of fluid into the bladder. That is first sensation. And I think it is important to record it properly. There seems to be a rapid rise in pressure now. So I think at this point of time, what I would prefer to do is to cut down the filling rate and stop contribution. It could be an overactivity. I will cut down the filling. So let us see if that leads to diminution in pressure. Does it? No. So what would be the opinion of the audience?
I think
It is not responding to the infusion volume. Is it rise?
Is it reducing now? Yes.
And it is not responding to the volume. When we stop the infusion, it continues to rise. This is why continues to rise.
But it is now reducing, is it?
Now reducing, yeah. Let's start the infusion again, but in lower rate. Make it 20. So everybody in the audience will understand the concept of compliance. A compliance is a feature of volume. Compliance is a function of the bladder wall. And thereby, the question always comes to how do you distinguish between the overactivity, which is a basic contraction, and low compliance, which is a tonic contraction. So you would have understood this because a phasic contraction is the one that goes up and comes down. A tonic contraction will go up but will not come down unless a volume is lost through leakage. So now she has some sensation. I think that the speed of is very high, that we are losing out of information, not losing it in the name. Leakage है क्या? Leakage mark करो क्या?
There was slight leakage here.
Yes. Leakage mark करो क्या? What is the volume? What said 129 ml of steaming volume. She had leakage of urine. Now whether it is because of overactivity or because of compliance, we will discuss that later. Okay, I'm not later, we'll discuss it now. So, talking about compliance, compliance is clearly a function of the Java volume. And remember, it is not difficult to distinguish between compliance and overactivity. I will explain to you now when we do post-processing of this case. Yeah. That's right. 140 ml.
Keep focusing, cameraman.
And she's leaking of it, right? Yeah.
Cameraman,
I think
please
now,
focus.
now, एकदम slow rate करो, 10 ml per minute, 10 ml per minute. So when did they say they stop the infusion? They say, number one, is strong urge to void. She may not have urges to void because she is urogenic dysfunction. And secondly, but the thing is leakage. If there is a leakage, then we stop it. But if the leakage must be as a part of low compliance, not as a part of overactivity. But we'll discuss that in post-processing more. Now we just do it not until some of this event occurs, either a painful urge or leakage, and then we will let her void. पेशाब करेंगे क्या वो? Now important thing क्या है ना, अभी उसको हम उठ के बिठाएंगे, तो बैठ के पेशाब कर सकते हैं, मारो कोशिश करें क्या लीकेज है? ओके फाइन, stop infusion now. Stop, no, yeah, let's go. Anybody in the audience can explain how we can distinguish between the low compliance and overactivity from the during the filling cystometry while doing it. Now we'll make her sit up. Now that sitting up should not change the reducer pressure at all. What should change is the rectal pressure, abdominal pressure may change. Okay. Put के बैठेगी ना, आराम से, can she just sit with legs spread out? Yeah. Okay. Yeah. Now, if we can look at the, very good. Yeah, that's fine. Yeah. When we look at the traces, yeah. The rectal pressure has gone up a little bit, but so has intraoperative. But the rectal pressure has unchanged. The rectal pressure is now 23. Okay. So she has lost 20 Very good. Now we will stop filling. Here, stop here. Okay. Can you give a permission to void? कोशिश करो पेशाब करने, जो कुछ होता है, पर हुआ तो हुआ, नहीं हुआ तो नहीं, कोई बात नहीं, कोशिश करो, ओके? Let us see a certain void. अभी देखना पड़ेगा, somebody has to watch. Okay, क्या permission to void here? अभी I just want to make sure that the transistors are measuring correctly. कुछ मत करो, just give the sharp pressure. Yeah, all right. We will confirm transistors are measuring correctly. Now we'll give a permission to void with the transistors measuring correct pressures at the moment. करो, जो है पेशाब करो, कोशिश करो. Are you watching the traces?
Yeah.
Yeah. What is your observation here?
So, there is some amount of abdominal straining we are seeing, but can you see that the feet detrusor pressures are
Correct.
not changing?
Hey, Dr. Sujata Patel is answering the question.
Yeah, they are falling.
Are there any students in the audience?
Yeah. Yes, there are students.
We have to get the mic.
Why don't we talk about?
Anybody wants to say anything about that law?
Yeah, is there any output at all? नहीं ना कुछ नहीं ना क्या देखा कोई वर्ड करके थोड़ा थोड़ा लेडीज बेटे देखो जरा यस लोग एक बार कोशिश करो जरा लेट अस जस्ट able to word is not able to word. You notice that she is training and training and training and नहीं ना okay. Alright, so we'll stop our investigation and we'll be there and we will discuss the rest of the discussion. Okay, let us see the entire graph in one, can you see in one frame from मिलेगा? एक frame में मिलेगा? अभी ना bladder empty करो उसका, we measure that volume now. हाँ, क्योंकि that volume could be different. Very often we infuse 250 ml and patient voids 350 ml. You know, that's a very common experience. And I'm sure the answer is quite obvious, isn't it? Everybody agrees with that? What is the obvious answer to that? Why would patient void 30% more than what was infused?
There was already some. Residual urine was already there, it was not emptied properly.
It is very different. You have to consider the diuresis that takes place, particularly in the patients with anxiety.
Right.
Diuresis will be faster, and you will also often get very large volumes. And therefore, this can give you a serious difficulty in managing the compliance or even big point rate volumes. So we have to actually measure the actual volumes at the end of voiding which we are doing now, and you will know what is her real bladder capacity. And I want to see the entire एक frame में दिखाओ ना.
Can we see the graph as well, please? Focus.
Okay, that's wonderful. Yeah, that's wonderful.
Yeah.
All right, fine. So now take it. Okay. Now here we go. Everybody agrees this is the intravascular pressure. That's the rectal abdominal pressure. That's the pressure. All right. Now, the only point is this cursor doesn't move, no? It moves. No. You can follow this pointer now. This is where the volume of the pressure started rising. I don't know what the volume was, but if you had a cursor, you would have known. Most modern neural equipment should have a cursor, a live cursor that will go on. Are you watching the trend?
Yeah.
Okay. So this is where the pressure change. Okay. This is called a break volume, and this is somewhere to the tune of 35 ml to centimeters, 35 ml. Okay, 35 to 40 ml. So this is where the pressure changes started occurring. And then look at this. Now this is interesting. There are waves of up and down, up and down, up and down, up and down. All right. But there is also a general rise in the pressure. Okay. Up to here. Also, general rise in pressure. So what I was explaining to you was how do you distinguish between overactivity and loss of compliance. Overactivity is a phasic contraction that goes up and comes down. So this is a typical overactivity, and which is irrespective of the volume. Well, volume will not decide the pressure. Okay, because if the pressure was say 30 centimeters, it has gone up to 35 and can come back to 30. Okay, that's overactivity. But compliance will be a feature or a function of volume in the sense that if you see the general rise in pressure, okay, and the pressure is, as soon as this volume is lost, the pressure drops. As soon as the volume is, there is leakage here. Volume is lost, the pressure is lost. Volume is lost, the pressure drops. Okay, so compliance does not change only with volume, whereas overactivity is a phasic contraction which is not connected to the bladder wall. Okay? So if you look at this, what would you say? What is it? Is it a compliance or a overactivity?
More of compliance.
Yeah. So obviously now it's a bit complicated, but you can see that there is a general loss of compliance, but there is also superadded use of overactivity. And these are very common features in many mobile situations. It's a loss of compliance and addition of overactivity. So these are overactive contractions. And if you draw lines from here to here, you'll find that there is general rise in the pressure proportionate to the rise in volume. Proportionate to the rise in volume. Now, if you measure the entire volume that comes out, you know how much is going to volume. So again, overactivity, producing leakage, overactivity. So, patient has a poor compliance bladder, which is detrimental to the upper tract for obvious reasons, because it is the sustained pressure against which the upper tract have to work. And therefore, this is the pressure that is the unsafe pressure or unsafe feature of the bladder. But in addition to that, we also have overactivity. And so this is the overactivity superadded to poor compliance. And obviously pressure has dropped because she has leaked urine through leakage. Leakage may have occurred because of this overactivity. But because leakage is occurred, the volume is lost and therefore the pressure has dropped. Now let's see can you expand this? Expand expand it is called expand. So I will just try and see the overall. Now anybody can give me some idea about this. Who can comment on this? This is the intravascular patient. This is the execution. So this is the wording record. It's been a good study in the sense that it's a good quality recording, no question about that. But if you see that there is a rise and fall in patients, there is some detrimental activity, and we can call it a voluntary activity, but highly inadequate, unsustained detrimental contraction. So she has to support with severe abdominal straining, but in spite of that, she did not void at all. Okay. Now, you can argue that she did not void because the catheter was there, but obviously she does not leak urine at a low volume. That's also true. And when she wants to void, she is not able to void even in a practical life. So obviously, there is some element of high outlet resistance. Now the question is this a sphincter, external sphincter flow, or is it bladder neck? Yeah. So we go back to MCU and see how it looks. If you look at the MCU very clearly, you find the bladder neck tends to open in all the films. And we can go back to MCU again. Bladder neck tends to open all the films. There is possibly a case of non-compliant bladder neck. Okay. No effective retractor contraction on the wording page. Filling place shows poor retractor compliance with superadded retractor overactivity, which in turn is responsible for urinary incontinence. Now, let's have comments from the audience on question.
So can you see the EMG activity there?
Well, it is not EMG simply because it is very difficult to or interpret EMG in this particular situation. And which is training, EMG will obviously show a signal. When we show signal, that is going. So, are we, you better ask questions to yourself. Are we talking about external sphincter activity? We're talking about pelvic floor activity. And to be truthful, EMG does not tell us that. The EMG that we do, surface electrode, does not distinguish between external sphincter bioelectrical activity and the pelvic floor activity. It will just show you a general bioelectrical activity of the pelvic floor and average. That's what it is. Therefore, EMG is not going to be useful in this particular case as far as the dysfunction of the sphincter is concerned. But you can get indirect evidence of sphincter dysfunction. Often these children with meningomyelocele have got spastic external sphincter, which fails to relax. And therefore it produces, it's called fixed sphincter obstruction. And that can be a cause of voiding inefficiency in this.
So do they correlate with the anal tone? Here the anal tone is.
What was the volume to recover?
Pardon?
Total volume कितना है ज्यादा? आपने FTP किया? नहीं, after completion of investigation, आपने FTP किया? नहीं, कितना आया कितना? 150. 150 ml. And you emptied the bladder, no? Oh, so that's okay. So if we had 150 ml, we increased 130 or so, and we recovered 150. All right. So now let us have this question, a few more minutes on the discussion here. What are the questions for the audience and what are the proposals for the management?
Yes. MC doesn't show it.
MCU doesn't show reflux, but there is bilateral hydrourethronephrosis on ultrasound, right, sir?
Yeah. So except the problem only is that we are not sure whether the proper voiding sequence was recorded in the MCU. The bladder neck seems to be closed in all the films, and we still don't know whether the patient has made an attempt to void at all. And we only see the films, isn't it? So that's also a problem. But if you could have seen the MCU or somebody, one of us had done this here, he could have made an attempt to void, but the bladder neck is not open. I think she has no reflux, that's for sure. At least not during spelling.
So if she doesn't have reflux and she has bilateral hydronephrosis and her creatinine is normal?
Yeah. See, obviously, I'm not worried about reflux in this case anyway, because I mean, her upper tract dilatation is not connected to reflux, suspicion of reflux. So obviously, we know that this is a hypocompliant detrusor with a high resting pressure. And that's good enough reason.
That's the reason why.
Yeah, that's a good enough reason. Plus, she has overactivity, and that produces episodes of incontinence in between. And that's why her mother is catheterizing her 5 to 6 times a day, and she prompts her mother get to catheterize. If she gets an urge, some kind of a sensation that she's going to leak urine, and then he prompts her mother, and accordingly she catheterizes and keeps her dry. So that gives us a lot of answers.
So at this stage, how do you rule out, so there is functional obstruction at the level of the uterocycle junction.
Yes, sir.
Yeah, and it could be also, as you say, there could be some obstruction at the level of the external sphincter.
Yes. That is a very common.
So these two things are there. Plus there is overactivity and low compliance.
Yeah.
So then we have to address all the 4 things, right?
That is true. See, spastic external sphincter obstruction produces 2 things. It delays leakage, but at the same time, it increases the midpoint pressure. You follow what I mean? So that means it allows more bladder volume and more bladder pressure before leakage occurs.
So with the kind of anal tone that she has, relaxed and energy zone. Do you expect the sphincter to be spastic?
In this case, it's very difficult to be sure. If the government was opening during the NCU, then we would have made a definite comment on that. But government is not opening during NCU. So she either hasn't made a genuine
Right. So we do not know exactly that.
exactly, yeah. So she either hasn't made a genuine wording effort, or she has the bladder neck obstruction as a part of her neurogenic picture.
So is it bladder neck obstruction or is it external sphincter?
You do get occasionally bladder neck obstruction. Yeah, you can get that.
So how do you differentiate between?
No, that is, I mean, a genuine MCU or a video.
Yeah. So we need to repeat the NCU maybe.
Yeah, I think a
Yeah.
good MCU with a good wording picture,
Yeah.
we will settle the issue.
Right.
But for the time being, what we can say is,
Yeah.
if 130 seems to be a critical volume for the bladder, all right, so she reaches the pressure about, what was the pressure last? 25? 27, yeah, that's right. So I think she has, at this point of time, 130 seems to be the critical volume, but you can increase the critical volume by giving her drug therapy like antimuscarinic, which I don't know which has received.
No, she is already on anti-muscarinic.
She already antimuscarinic.
Yes.
What antimuscarinic is she
I
on?
mean, oxyglutamic, right?
Oxy?
Oxyglutamic.
How much dose?
2.5 PDS, yeah.
2.5 mg. Yes, certainly. So it is overactivity and it is low compliance both, and there is no voluntary body compliance. That's what it is. Fine. So 130 ml is the aim. I would increase it. You can give her a trial of botulinum toxin. The only thing is botulinum toxin needs to be repeated. But at this age, I suppose 100 units of botulinum toxin should be sufficient, and give her a fairly better compliant treatment. Obviously, there is no guarantee of it. There's lots of compliance is one thing that botulinum toxin doesn't work very well again. But yes,
Dr. Sirish, why do you want to give Botox here? Because there's a poorly compliant bladder, it's not able to produce venous contraction.
chance because we have overactivity as well.
So
There is a chance. I mean, it's something that we can discuss with her, and we can, if she's willing to accept Botox as a part of her therapy, we can give botulinum toxin. And I think 100 units will be more than sufficient in this trial.
okay.
Because voiding anyway is not a problem. I mean, it is a problem in the sense that she needs symptomatic catheterization anyway, isn't it?
So Botox 100, and where would you give
100 units.
in the diffuse tissue, right? Diffuse area.
Yeah, as diffuse as possible.
Okay.
At least 25, if you 125. Tell her that she might need to repeat to my months. But yes, I think that should be fine. So that will at least, for the time being, it will reduce it will increase the interval of catheterization, and at the same time keep her bladder safe.
All right. So suppose the Botox doesn't help much. All right. So we gave Botox, but it didn't help.
But I think the only other option is augmentation. But I don't think she will candidate for augmentation. She has done pretty well for 10 years in life. So I think we should manage her with just adjusting the drug and adjusting the interval between catheterization.
I say for hydronephrosis keeps on increasing or the creatinine.
Yeah, it has not taken a toll on creatinine yet, but
Not yet, but
yeah, but
yes.
it's a moderate hypernephrosis.
Yes, the moderate to severe, yes. So again, if the Botox doesn't work, then I think yes, augmentation.
Botox should work at least partly, because the overactivity will be abolished, the leakage episode will be abolished, and it may sometimes help to comply.
But when the bladder has already produced an anatomy to change bilateral.
Yeah, that is the argument. I can understand the argument. Yeah. And we always find that at least a third of patients show improvement will go to the toxin even with the low compliance.
I agree with you that we can increase the dose of anticholinergics to the
Of course,
maximum.
then
We can add alpha blocker.
that is what I would do. Alpha blocker, where would they work?
The only, yeah, we can adjust the timing of CSIC so that it doesn't exceed 150 ml. We can do all this, but it has, when anatomical change has been
Okay,
proven,
that is always the argument.
indicates that the no longer complex.
Yes, that's the valid theoretical argument. That's the reason Botox works very poorly against low compliant bladders as compared to this is overactivity. Yeah, that's true.
So then what is your cutoff of saying that we go ahead? Do you say that
Cutoff what?
cutoff for going ahead for surgery or
Oh, I think, see, this is the first time we are seeing her. We need to see her after 6 months, follow her every 3 months in the OPD, and let us see how she is doing. If she has, if incontinence cannot be controlled easily, or if there is any change in her upper tract morphology, or even shows in serum creatinine level going up, maybe she becomes a candidate for augmentation. Preferably microphone, yeah.
So now let's say MCU, if it shows a kind of a bladder neck obstruction.
You want to say it again?
No, MCU we have seen.
I think we should
Yes.
see MCU again.
Yeah, we did that. Suppose we have done it again and it doesn't open.
That
Right.
will not change the plan much, Shivam, because it is only theoretical consideration that she doesn't have a bladder neck. Much more common is the external sphincter, much more common than bladder neck.
Okay, suppose there is a kind of resistance and external sphincter. Then do you think sphincterotomy?
No. I mean, ultimately also think of quality of life. We don't want to make her permanently incontinent.
Yeah. No, but if suppose the upper tracts are deteriorating.
Augmentation is a choice.
Augmentation.
Augmentation is a choice.
Augmentation with even the external sphincter resistance.
Correct?
With the increased external sphincter resistance.
Augmentation?
Augmentation with methylphenol.
We can catheterize very well urethral. We will not give up microphone. But I usually children, I use microphone because it's always a choice of a, you can decide to catheterize either by the microphone or by the catheter. We always have a choice. And you can't do it second time when you go to second stage. So do it, if you don't do it, it is the first stage. In children, if I do my augmentation, very advanced them to have negative operating.
Anybody in the audience has any question? Anything?
Yes, please. I mean, would like to see the audience interaction.
Yeah.
Yeah, these are very complex situations. So,
Yeah.
We need to discuss over and over again.
So do you think these patients also come across frequent urinary tract infection also, and that is again another factor?
Infection?
Yeah.
I think we need to have a history of having bad infection. Now, whether you should manage it, CIC pretty well. For 5 or 6 times, without any demonstrable or any probable test of UTI.
So if suppose this was not a girl, it was a boy, and maybe, so what do you think? Would have
Yes, and then the only question of the boy is catheterization is slightly higher. And therefore, our threshold for microphenosis is lower. I mean, we would try to advise microphenosis more readily to boys and to girls. But I think augmentation is extremely well. And although there are so many objections to use augmentation in the long run, I have got 3 women on whom I have already children. And now the question has come of their pregnancy and managing their obstetrics. What I mean, with augmentation, the entire mesentery of the bladder, of the new bladder, happens to lie in front of the uterus. Okay. And I have got three girls now. One of them already over, and two of them are pregnant. And I was going to register the Ruby Hall. But if they need cesarean section by any chance, I should be there because it's very difficult for anyone to find out what's happening to them presently in front of the uterus. Isn't it? When they come to the question of cesarean section. But we told them that we have also warned the obstetrician that this will probably be needed and we will do the hospital section, taking care of measures. So that is the issue. It does two things. Number one is they're doing pretty well. And number two, they come to the stage of marriage, pregnancy, and go to the very normal cycle of life, which is very gratifying. So we should not worry about her needing augmentation with these things. It should still give her a good quality life. Okay. Yeah. Let's show the discussion with the meantime. We'll go ahead with the next case. It's a male. Yeah. But again, a child with young person.
Dr. Shri, I think it is 4 o'clock. Do you think we should take a next case or we just do a case discussion and?
So whatever. I mean, if the choice is yours, sir.
What we can do is, let us start the next case. Here we will start the case discussion. And in the meantime, we might show some of the.
Okay.
Yeah, right? So.
You have cases to discuss.
Yeah. We will, we will do case discussion for about 15-20 minutes.
Give me interesting case actually.
Okay.
थोड़ा ये आप जरा नीचे करेंगे थोड़ा क्या
Yes.
It is knees here. Can he come in front? Yeah.
Right, I can see.
This boy, come. आपका नाम क्या है? हिंदी बोलते हैं ना? Okay. Now I don't know his history, but apparently he has got a history of posterior wall configuration in the childhood. Look at his legs.
So he is a 19-year-old child with the symptoms of recurrent obstructive roots and recurrent acute retention from last 14 years. In past history, the patient has undergone an endoscopic UV fulguration 14 years back, after which the patient was completely fine, voiding completely fine for 5 years, and he went into sudden retention, acute retention of urine, for which he was catheterized for 1 month. Post first retention, he was fine again for 2 years, but after 2 years, he had symptoms of obstructive roots and spleen staining, and he was increased frequency was there, and then he again went into retention 1 month back, for which he was again catheterized for 10 days.
Yeah, do you know how much volume came out on catheterization?
Each catheterization, the gold was of 800 ml.
800, yeah. That's a very good piece of information. Was this a painful retention?
It was not. It was a painful retention. It was a painful retention, and as far as the bowel habits are concerned, he has a symptom. He has no symptoms of constipation. That
what is his renal status?
The renal status, he is a chronic kidney disease patient from last 3 years.
Okay.
And he has a creatinine of 4 to 5, for which he is on chronic medication, sir. He has not undergone any hemodialysis till now, sir. And post
no hemodialysis.
No hemodialysis.
What's his creatinine now?
Sir, right now it is 2.9, sir.
Achha.
Yes,
not very high.
Before the last retention, sir, on admission, his creatinine was 5, and after catheterization for 2 weeks, his creatinine came down to 3.
And is he doing anything for voiding now?
No, sir. He is not doing anything. He is just voiding with training.
Okay. And what does the ultrasound show?
His ultrasound shows severe hydrouretal necrosis on bilateral kidneys. Severe hydrouretal necrosis are there, sir. And bladder is also, sir, distended, and walls are minimally thickened, but keyword volumes are 691 and post void is 386.
Okay. Right. Massive dilation now. This, yeah. Dr. Shivam, just to summarize this case, he is a patient who was probably born with a posterior valve, but at what age?
At the age of 9 years.
9 years. So it was pretty late. But what has happened is it has probably taken the toll afterwards. And as we all know, posterior valves is a disease of almost a lifetime because the obstruction occurred in utero when the kidneys were in the developmental stage. So anyway, what has happened is he has got box knees, he has got rachitic lower extremities, he has a creatinine of 2.9 as of the catheterization, and he has got bilateral upper tract dilatation and a large residue. So obviously, his bladder is unsafe. It's probably some variety of valve bladder. I would expect a poorly compliant bladder in this case. But basically, not been looked after adequately in the past. That's right.
So on examination, the local examination, the meatus is normal, sir, and the penile shaft is normal. Perianal sensations are normal, sir.
Is the bladder palpable?
So bladder is not palpable.
Not palpable. Okay.
And perianal sensations are normal, sir. And on digital rectal examination, the anal tone is normal, sir. Bulbocavernous reflex is also present.
So he's neurologically normal. That we expect in the field also. His neurologically should be normal. But these valves are produced to detect the toll in the behavior of the bladder. Poorly compliant bladders, very common. The residual obstruction is very common. They may have urine stricture in response to various procedures in the past as a child. And obviously, he has got upper tract dilatation. So if we don't have time for doing somebody got a bottle of water. It could be different bottle, of course. Yeah. But anyway, so if you don't have time for demonstrating, let's go ahead.
No, we can go ahead.
Okay.
In the meantime, you prepare the case. We will have something else.
Yes, try to get a few minutes
Yeah.
for the discussion.
Right.
Okay, sure.
So prepare the case.
Yes,
And keep.
thank you.
Right. All right. So, Sahaj, have you done a cystoscopy in this case yet?
Sir, no, sir. No cystoscopy has been done in this patient.
Do you have the NCU?
Sir, no, MCU was not done in this patient.
So NCU should.
Okay.
Yes.
Sir, he was catheterized with a normal catheter, 14-20 last when during the retention.
So you think there was no treatment, but yes, NCU still should be done.
Yes.
Yeah.
Go very gently.
So he's having pain, a lot of pain, right? Because he doesn't. Yeah. It might be such gear like this. So what we'll do is.
So in this child who had been treated at posterior valve, and now the whatever information we have got, that is creatinine is on the higher side. He has bilateral hydrourethronephrosis, and he has stunted growth and everything, history of chronic renal failure. Here, what we need to see is there obstruction at the level of the posterior valve because of the procedure itself? Because stricture relieves his obstruction, catheterization for a few days relieves his obstruction, again he goes into obstruction. So that cannot be a feature of valve bladder. Because if it was only valve bladder, then the difficulty in wording and everything could have been persistent. So there could be a possibility of stricture. So an MCU is a must. Secondly, we have to rule out reflux, because we know that valve bladders are small in capacity, they are poorly compliant, they are associated with reflux. Plus, there is always associated interstitial nephritis, and that produces an increased volume of urine at night. And that in turn leads to the additional bladder damage which occurs, because these bladders are at night, they hold very large volume of urine because of the diuresis which occurs at night. So all these features, whenever you are thinking of a posterior valve, you have to look. So in this ultrasound, as students, you should also ask whether there is any insulin echogenicity, what is the cortical thickness, not only they said hydronephrosis, so active hydronephrosis. You have to see whether there are microcystic changes in the renal parenchyma, which in turn suggests that they have developed interstitial cystitis. So these are all the points you should ask whenever you're talking about this patient in an exam. Okay. And obviously we need his MCU definitely. So we can go ahead and talk about it. Yeah, so it's possibility that he, after catheterization, he voids well for a few days. Maybe we are dilating that narrow area and he's voiding for a few days. Again, he's going into retention. So additional feature could be narrowing plus gallbladder plus all things together.
What we will do is, meantime the case is getting prepared, we will take up the quiz, right? Because
Yeah,
the quiz has been prepared and we have prizes also for resident. And if we have time, then we will have some kids.
Yes, sure.
So I think all the residents are inside, so anybody outside. So if there are some residents outside, please call them. Right? How many questions do we have? So we have 15 questions. We need to answer them. Put them on the paper, and then we collect the paper and then try to see who has scored the highest. So, Dr. Sudeep will do the quiz. Yes. So we'll keep watching. दोनों एक साथ तो नहीं कर सकते, एक साथ ठीक. Wait, so we'll finish.
On behalf of Dr. Mendelssohn, I will be presenting the quiz. So this is the first question. A 57-year-old female who presented to us with complaints of urinary incontinence underwent a urodynamic study, and the circles in this study, do they represent detrusor activity? True or false?
Point of view. Thank you. 15 seconds. प्रेशर लिखे हुए हैं.
Next question.
Right, so we go to say next question, right? Okay.
A 68-year-old male with DPH underwent a urodynamic study. The circles in this study represents what? Detrusor activity, detrusor underactivity, a provocative maneuver like cupping, or just an artifact. Detrusor overactivity, underactivity, provocative maneuver, or artifact. So the next question, 37-year-old female with past medical history of multiple sclerosis, with complaints of urinary frequency and urge incontinence, underwent urodynamic study. Based on the tracing given below, the diagnosis is a bladder outlet obstruction, a DSD, an intrinsic sphincter deficiency, or it is just a normal body pattern. Outlet obstruction, DSD, intrinsic sphincter deficiency, or normal body pattern. Which of the following is incorrect? The first sensation of filling occurs at 50% of cystometric capacity. First desire to void, that is normal desire, occurs at 75% of cystometric capacity. A strong desire to void occurs at 100% of cystometric capacity, or none of the above. Reducer overactivity occurs if the P dead is more than 15 centimeter water during filling, or more than 20, more than 25, or more than 30 centimeter water during filling. Overactivities. Which statement is false regarding bladder compliance? It is a relationship between the bladder pressure and the bladder volume. A value of less than 20 ml per centimeter water is consistent with an impaired compliance. Passive component depends on bladder wall composition, or none of the above.
Which is false.
Coming to the bladder outlet obstruction index, is it P dead Qmax plus 2, P dead Qmax minus 2, P dead Qmax minus 5, or P dead Qmax plus 5? Which of the following is not Nitty's principle in urodynamic? A study does not duplicate the patient's symptom is not diagnostic. Failure to record an abnormality does always rule out its existence. Not all UDS observations are clinically significant, or all of the above. Which is correct formula? P dead is equal to P abdomen minus P vesicle pressure. P dead is P vesicle minus P abdomen, or P dead is equal to P vesicle plus P abdomen. Which of the following tests assesses bladder compliance? A cystometrogram, a micturational urethral pressure profile, a voiding pressure flow study, or an electromyogram? Regarding video urodynamics, it is the most precise measure of low urinary tract function and should be used in all cases in which UDS is to be performed. It is required to assess the obstruction in a man. It is a procedure of choice for documenting bladder neck dysfunction in men and women. It is impractical to perform in spinal cord injured patients. The true.
Which is true, yeah.
Which is the truth. During multi-channel urodynamics, what is the best measure that allows the clinician to look for abdominal straining occurring during micturition? A rectal or vaginal catheter pressure, a rectal or vaginal catheter pressure, a bladder catheter pressure, uroflow pattern, or a electromyogram activity with uroflow velocity. During multi-channel urodynamics, the best measure for abdominal straining during micturition. Rectal pressure, bladder, uroflow pattern, or electromyogram. All of the following urodynamic findings are potentially dangerous except impaired compliance, high pressure detrusal overactivity throughout the filling, a detrusal leak point pressure less than 40 centimeter water, or a poor emptying with high storage pressure. All of them are potentially dangerous except.
Slow, just wait. Yeah. Repeat this.
All of these following urodynamic findings are potentially dangerous, except one of them. Impaired compliance, high bladder pressure, high pressure detrusal activity throughout the filling, detrusal leak point pressure less than 40 centimeter water, or poor emptying with high storage pressure. Which statement is true regarding maximum urethral closure pressure, MUCP? Which of the following statement is true regarding the maximum urethral closure pressure? Most continent female have MUCP of 40 to 60 centimeter water. MUCP of less than 20 centimeter water is defined as ISD or intrinsic sphincter deficiency. Both 1 and 2 are correct, or none of the above. Bashful bladder is a low pressure with low flowing voiding bladder, a high pressure with a high flowing voiding bladder, a high pressure with a low flow voiding bladder, or all of the above.
So all of you just write your name and mobile number also. Right? Fine. So we can. Naveen, please collect. We have the audio.
Rahul.
Hello. Let's go on. Hello. So are we connected to the Urodynamics?
Hello.
Yeah, there you are. Yeah.
So we are doing the filling cystometry.
Right.
Till now 160 ml of the volume has been infused.
Yeah.
And patient is not having any sensation till now of bladder filling there.
Okay. So what is the filling rate?
30 ml per minute is the filling rate there. Last bladder is
Yeah. So his bladder volume capacity was also very high.
yes, sir. 700 cc on day. 700 cc volume.
Wow. What is the rate?
Yes, sir. Yes, sir.
What is the rate? Can anyone tell me?
What is it?
There is a wave which is now shifting to the left.
Sir, that was the cough and pulse. Sir.
Huh?
Cough and pulse. Sir. We asked the patient to cough.
No, it is not cough impulse. If it's a cough impulse, you see it in intravascular pressure also, isn't it? What does the pressure show there?
The detrusor pressure.
Which one are you?
2.
Yeah. So come back to the head again. Have we stopped? Have we stopped the head?
Yes, sir.
Stop, yeah.
Yes.
Yeah. Just zoom in for the screen again. And let's have a You see, it's a lot of glare on the screen. Zoom in, purpose. Let me see. It's a good question, everybody. Can you?
The screen is clear now.
Stop. Stop. Then extreme back thing. Did you listen? Go on. Can you? Oh no.
The previous.
You can't stop it in the middle, yeah?
Yes, sir, the curve.
पर कंप्लीट करो बाद में देखेंगे because there's something which I wanted to ask everybody. It's very interesting.
We are just scrolling to that curve.
Okay, you can scroll it up.
Yes, sir.
Can you scroll it now? Okay. Now, yeah, right on the left of midline, you can see a deflection on the abdominal pressure. Okay, not that one. On the left of that.
Left of that, this curve, yes.
That one, yeah, what's that? Correct. Everybody.
हाँ, rectal क्या है?
Anybody has any?
नीचे ये invert हो गया ना? Yeah.
Yeah, okay.
Rectal contraction.
So what is that wave? Hey, anybody in the audience is very simple. Discussion, there is intravenous pressure, show me intravenous pressure, there is no change. Okay, rectal pressure, there is a change.
The rectal contraction.
This is the rectal contraction.
Rectal contraction.
And let us have the audience feedback. What is it?
Huh?
Who said rectal contraction?
Sir.
Sahaj?
Yeah.
Very good boy. He's brilliant boy. I mean, see, look, this is what it is. People pick up these things on observation easily. See, you can see no change on the intravesical pressure.
Right.
Take the pointer intravesical. No change there. Okay. There's a distinct wave on the rectal or on the abdominal pressure. And look at the detrusor. What has happened?
Yeah, it is
It was a rectal the abdominal pressure rise. The computer managed to subtract it and therefore gave us a negative reflection on the detrusor. So that was a rectal contraction. But it's very common. Rectal contractions can come in the middle and may actually complicate the recordings. But it is a rectal contraction and very clearly shown. And what is it? Immediately follow the rectal contraction.
This is the cuff impulse.
Exactly, pulse. See the intravesical as well as abdominal. Yeah. So we should not miss that rectal contraction. You must be able to spot it because then otherwise it will create confusion in interpretation. Now we know it is rectal contraction and it's known to occur. Rectal contraction, particularly in children and in neuropathic glands. Okay.
Then we can go to the
Okay, go ahead.
here. So 198 already, right? So
Yes, sir.
no change in the detrusor pressure. Right. So patient still doesn't have any urge, right?
No, sir. No urge, sir. Okay. So, let us click.
Yeah. So in high capacity, the large capacity, do you think the filling rate should be still higher?
Yeah,
Like 40, 50, we can do 40, 50.
Generally, we know it beforehand.
Yeah.
Ultrasound reports
Yeah.
and frequency was which are high capacity product. And if you're not expecting anything like poor compliance and reduce overactivity, you can stick to 75, 80 ms per minute. Yeah.
So then we can still at least go to 50, right? Is it 30 ml?
Yes,
Right?
50 ml per minute.
Yeah.
You can make it 50 because it's a large bladder capacity.
So he says it has a sense of bladder filling. Sir.
The only problem is you should not see an artificial rise in detrusor pressure.
So we asked him to cough once right now, sir.
If that happens, then we'll have to slow down and stop the
Yes.
infusion.
Yes.
So which position the patient is? Is it
It is fine.
supine completely?
Yes, sir.
Okay. So why do should it be supine or do you want to make a sitting?
Yeah, I think you should sit up.
Yeah, it's called the बैठा दीजिए, बैठा दीजिए.
You should sit up because he's
Chair for-
providing is sitting up.
We are making it back erect.
Right, right.
Now patient is in sitting position.
Right.
Okay, let's see what has happened to the traces.
Traces दिखाइए.
Yes, sir.
ट्रांसड्यूसर को भी आपने चेंज किया क्या? Is it
Sir, it is at the same level as
Same level?
Yes.
Okay.
But actually, by making you sit up, there won't be much change in the physical simplicity level.
Yes, sir.
So after transfer change किया, I have taken it above the limits of versus. Can you see the transducers?
Yeah, he's saying it's at the same level. Yeah.
What changes do you expect in a sitting position? Or even say standing up position, what changes would you expect?
Oh, at the transducer level?
Sorry, sir.
In pressure measurement and in pressure values.
Okay.
Sir, if the transducers are at the level of cubic synthesis in sitting and supplying structure,
No, so what will
No, no. Will there be any change in the pressure? Is
pressure intravesical?
intravesical, I understand. That is,
Would
does
you,
it change?
would you expect a change when the patient sits up from supine position?
Yes.
Somebody who is doing urodynamics every day alone should be able to answer the question easily. शर्मा जी को मत पूछो, आप खुद में। अरे, what is the answer to my question? Nobody is answering.
Sir, increase would be there, sir.
Huh?
Increase in the intervention.
How much increase? Depends on the build of the patient. You should expect about 20 centimeters rise in intravesical as well as abdominal pressure. There should be no change in diffusion pressure. If the patient is obese, it can go up to 35 centimeters each. But of course, no change in diffusion pressure. You can increase the infusion rate. How much is it?
It was desired to void at 410.
Okay. The first desired word, right? Yeah.
The screen is moving very fast. Can the speed be adjusted on the screen? Okay, we will see it later, but you know, sometimes you see something and then goes.
Focus ठीक कीजिए. Cameraman, focus. Focus. Slightly better. Yes, understood. Yeah.
Changing the bottle of ingredient to
Okay, so what is the findings so far? You don't ask him to cough in between. I think you must. And make sure
They had just,
ask him to cough. Yeah.
Sahej asked him to cough.
I request you every minute actually.
Yeah. Yes, yes, very good.
That gives you a reassurance.
That everything is going on fine with that.
Right? So,
Till now, sir, 515 cc has been used,
Right.
and there is no increase in period dose, sir, so it is a highly compliant. Very.
And
520 cc has been used, and there is no increase in feed reducer till now, sir. So compliance is on the higher side, sir. Highly compliant.
is it normal or is it abnormal?
what does that mean, man? Is there something called high compliance?
So placid blood, it is a placid blood.
So no detrusor contraction. So you think there should be detrusor contraction in normal blood, is it?
This capacity, sir.
At this capacity, okay. Slight rise, is it?
Right, right, okay.
So that slight rise is still not. Okay.
I see you still cannot comment on capacity because you have not reached capacity.
Yeah.
But obviously,
Yes.
this is the hypercompliant, diffuser, hypersensitive, delayed compensation. What is his normal volume blood volume?
That is around 600-700 of that.
Do you have warning diary?
Sahej,
Sir, body diary,
no, but his, he was holding around 7,800 ml.
his hold was 800 cc on, reservation.
How much is body?
Sir, he's holding around 6 to 7 times daily, sir.
So what is the volume?
Sir, around 3 to 400 cc.
400. Okay.
On residue?
Residual urine कितना है?
Sir, 380 cc was the residual unit.
Yeah, and his free white was around
700 cc. 691.
691. Okay. So, Dr. Sirish, this is the case of posterior cell bladder. Again, posterior cell bladder, while patients have bladder dysfunction. So they can be of either type, related to overactivity, hypocontractile bladder, and mixed type. So this appears to be a hypocontractile.
We don't know about contraction yet. We only know the high capacity and more sensations. Yeah.
Yes.
Yeah.
Or it could be a poor compliance.
And capacity is increased. And compliance is increased. Yeah, that is what all I can say. But whether it is a hypocontractile, it would be, but we don't know yet. Unless we ask him to go.
What do you see in
Sensation, what's happening?
Sir, he is just having mild fullness in the lower abdomen, sir.
Yeah, so really speaking, his sensations are extremely delayed. Now, as Dr. Shivam explained, it would be hypocontractile. We all expect it to be, yeah. But you only know about it when we see the voiding phase. Is he ready to void or not yet?
So till now, he is not having any urge towards.
Okay.
But I'm surprised there is no multiple bladder.
Till now we have infused 720 cc.
Abdomen में क्या लग रहा है कान? Is it appears to be
It is visibly full, sir.
very full? Yes.
One finger below the umbilical. One finger below the umbilical. Sir, he is having now urge towards
Some activity, yes.
he has urge towards.
Right. So normally he voids in sitting or in standing?
Now the question is he used to wording standing up or sitting?
Sitting.
If that's the case, make him stand up.
Yeah.
Sir, he usually voids in the standing position.
Yeah.
So ask him to stand up.
So let him stand up and just adjust the
So we
control.
stop filling or we should continue filling?
Make him stand up. That itself is like a call.
Yeah.
Your
So we should stop filling the bladder or we should continue filling the bladder?
but make him stand up first.
Feeling continue रहने दो.
Continue filling for another minute or two. Yeah.
Yes, sir.
And ask and उसको आप बिल्कुल सीधा कर दो.
Yeah. The detrusor position will show forward.
Yeah. खड़ा कर दिया क्या?
Sir, correct.
Okay, आराम से take care.
The posture problem is there.
कोई बात नहीं, take care.
Don't change transducers. Let us see what happens and then change. Transducers can only be changed if there is a change in the height of the symphysis gradus. Either short stretcher above, they may not really change.
Sir, अभी कर दिया है sir.
ठीक है. Standing कर दिया.
ठीक है.
I think it's give transducer as long as.
ट्रांसड्यूसर में कोई चेंज मत करो कह रहे हैं कि शायद कोई फर्क नहीं होगा.
Suppose that you move the transducer and take it below, say what 20 centimeters, what will happen?
Sir, we should give the permission to work.
What will happen? I mean, what exchange would you expect? Suppose you take transducers down by 20 centimeters.
यदि ट्रांसड्यूसर 20 सेंटीमीटर और नीचे चले जाएंगे तो क्या कुछ फर्क पड़ेगा?
Just both stand-up transducers along with the tubes, of course, intact. What will you expect? Anybody in the audience asking a simple question, what would you take transducers down by 20 centimeters? What could you expect in the prediction recording?
So has he desired a void? Yes.
Sir, he has a
Stronger. He's standing,
yes, sir.
but still not able to void, right?
And we have not given permission to work.
But has he got an urge?
Yes, sir. Yes, sir. Strong urge.
So permission did.
I can't be here to check on patients. Yeah, patients are okay. Yeah. We'll have to stop infusion first.
Yeah.
We are given almost 900 now. There will be some by diuresis as well. So almost 1,000 ml in the blood now.
So we stop the infusion.
Yes, stop the infusion.
Stop the infusion.
Yes, sir.
But making cough before you,
Making cough first.
yeah, before you give the permission to void. Yes.
Making cough, please.
Confirm that. Yeah.
Yes, sure. Good.
Very good. Yeah.
So now you can just ask him to stop the infusion and ask him to void.
Yeah. Yeah.
करो शाम को करो निकल करना करने और दो
आराम से रिलैक्स जैसे करता है नॉर्मली वैसे. वहां पे आसपास लोग हो तो उसको थोड़ा सा बाहर जाने के लिए कह दीजिए.
Is the permission given?
Yes, sir. We have given him the permission. It's trying.
it's important to ask him to void as he normally does. Okay, but when you ask him to void, you usually strain. If it is abnormal, then you must know about it. So ask him to void as we normally do.
सहज इनको कहो कि बिल्कुल जैसे नॉर्मली करता है पेशाब करे.
Does he void by straining normally?
Yes, sir, he has to strain on
Ask him, yeah. Ask him to produce a void. As what normally do.
जैसे नॉर्मली करने का कोशिश करता है. Yeah.
There is a contraction.
He is voiding.
Okay. Yeah. You can say that.
Yeah.
Yeah.
So,
So distribution over 65. So has he stopped voiding? Because he not contracting. Yeah, distribution is still coming.
He has urgency, but he is unable to void it.
Yes.
So if he keeps on like this, then should we remove the catheter and then ask him to wait? Yes. So how long should we wait?
Yeah, we could do that now. Yeah. See,
अब अपन कैथेटर निकाल सकते हैं, कैथेटर निकाल के उसको void में.
we know that he can void. Now we can remove his catheter, but just keep the catheter at the same level as this cubic simple system. Don't throw it on the floor. Because if you put it on the floor, then there will be an abnormal rise in pressure lines. And ask him if he can void. Now we have to disregard the pressures.
Yeah.
We must know the point from which we disregard the pressure.
तो अब उसको पेशाब करने के लिए कहो.
Put a marker there, yeah.
ठीक है, suddenly was about mental so high.
Is he voiding now?
No, sir, he is not voiding.
Not voiding?
Yes, sir. He has,
I think he has completed his void. How much did he void? 58? Is it the correct picture? 58 is the correct figure? It looks like much more than that.
because he has voided 58 is the only reason.
58?
Yes, sir.
He's not able to void now?
Sir, he is trying the
हाँ सर
Right.
हाँ
So he's saying he'll
हाँ पढ़
so he's saying he'll be able to avoid.
हाँ आराम से उसके करवा लो आराम से relax
Is it able to avoid? There are no tubes in the urethra.
No, sir, no tube in the urethra.
I have quite often, there is some kind of a painful sensation in the urethra and that inhibits the voiding, particularly in patients who have voiding difficulties. Okay, so I think we will stop here because we have to stop.
Yes, sir.
So you voided only about 64 ml, right?
Yes, sir.
Okay, fine. So let us just quickly summarize the findings and it's. Okay, so now, can you summarize the findings?
Getting it on one.
Yeah, if it's a physical symptometry, I need to look at sensations, compliance, overactivity, capacity. Sensations, compliance, overactivity, capacity. So let's comment on those four issues. And wording is concerned, we will take those points later. So sensations, compliance, capacity, overactivity. So can someone say, so Sahej or something with there?
Yes, sir.
Comment on that. Yeah.
Yes, sir. Yes.
All the 4 points here. Very good. I think that's good enough. So tell us quickly what you find. Sensations, overactivity, compliance, capacity.
First curve is of intravesical pressure. The second one is abdominal, and third one is detrusor curve. And this is the volume infused plus the bladder, sir, the green line. Initially, sir, there was during the filling phase, sir, there was no increase in the abdominal intravesical pressure or abdominal pressure or detrusor pressure during the filling phase, sir.
No.
Towards the filling phase, there was no increase in the pressure of the detrusor, sir.
No. What were the voiding pressures?
On voiding,
Put a marker there and see what was the maximum voiding pressure. Maximum voiding pressure. Oh.
this was the permission to void which we have given, sir. At that time, sir, maximum pressure of detrusor and voiding.
Cannot put a marker there and see.
This is the maximum pressure during the voiding phase of detrusor, the detrusor maximum.
How much?
It's value is. They're just getting the value.
Okay, The software should allow you to do that. How much is the voiding? But they're about 64, 68.
But the voiding pressures are maximum voiding pressure and the
Feedlet max was 54.
maximum was 54 centimeters of water.
54, that's not much, yeah.
Okay. Feedlet maximum was 54 in the voiding pressure.
Okay, okay, okay. And what else? Let's go come back to the place again.
What is it?
Come back to the place. So tell me, capacity has increased, the sensations have diminished significantly.
Yes, sir.
Okay, components have increased.
Yes.
And there is no overactivity.
Yes, sir.
In voiding, how can you qualify voiding? Go back to the place again.
Yes, sir.
Now tell us about voiding. What is the voiding? What is the voiding suggest?
So on giving permission to void, sir, first there was hesitancy, sir. Patient was unable to void in the starting, sir.
He was able to void it. The void is explained also. You want
Right,
to
The voiding, sir.
in that case, we saw voiding.
समय अपन ने देखा था ना.
Of course.
This was the permission given for voiding, sir.
But he voided, now there was a flow, isn't it? Where is that flow?
Okay, so
This was the.
Acha. Okay.
what are your observations? Let's quickly summarize. Because then I will-
So that this is an interrupted pattern, so voiding on training only, sir. There are two spikes of voiding, sir.
I can't see the top part of it out. Can you bring it down a little bit? Okay, that is not,
So abdominal straining is that much not that high. There is a reduced pressure also.
see, what we could see by tree is that voided a little bit.
Yes.
But at the expense of slightly higher degrees of pressure,
Yes.
which is what in the rate of 54 you said.
Yes.
Some rate of 64 at most, at least according to the graph, but anyway, it doesn't matter. 54 is okay. Can you comment on the outlet?
Sir, higher diffuser pressure and low flow, sir, is suggestive of bladder outlet obstruction, sir.
Okay, how do you substantiate your claim?
Because there higher diffuser
Yeah,
pressure
see,
and low.
yeah, and I just summarize it again. Yes, if you take the pressure flow into account,
Yes.
you will say that if pressure flow does suggest obstruction. Now, I will substantiate further saying that he required a lot of straining. Look at the intravascular pressure going up. Okay, in fact, rectal pressure hasn't gone up that much. I don't know why, but I'm going because the difference between diffuser and that. But if he requires such a high amount of straining to produce that little feeling, then your suspicion of obstruction is further confirmed. Okay, so there is an obstruction. What about diffuser behavior? Is it normal? No, it is poorly sustained. Hey, diffuser normal behavior is the one that lasts until the completion of voiding. But it hasn't. Diffuser failed to contract and it did not contract at all after that. Isn't that right?
Yes.
And you can actually comment at diffuser contraction, the other outlet is closed. Therefore, whatever contraction is there, it transferred into diffuser compression, as we discussed in the morning. So yes, there is a severe degree of underactivity in terms of sustenance. Okay, agreed?
Yes.
That's number two. All right. Other question is, and further, as I said, you needed to strain so much to produce. That substantiate our suspicion of
obstruction, because he also has to use an abdominal force to produce the body, in addition to the reclusive contraction. So it's substantially a diagnosis of obstruction. Can you make a diagnosis of obstruction in the absence of flow?
So if there is higher feed intrusive during voiding, there
And no flow,
no flow, there is no flow. Yeah.
no flow.
Yes, sir.
So what will you say?
So, it would be suggestive of lateral outlet obstruction.
No, strictly speaking, in the absence of flow, you cannot diagnose obstruction because you don't know what the sphincter is doing. You don't know what the pelvic floor is doing. It's only when the flow occurs, then the pressure flow relationship takes relevance. Okay.
So even if the patient is asked to void, and he has been given the command to void, he is trying to void, and still is not able to void. So you think there is no influence happening?
I think technically, speaking, diagnosis of obstruction is a pressure flow relationship. And therefore, there must be some flow to come so that the bladder outlet is more open. In absence of flow, you cannot diagnose obstruction.
So have retention, they cannot be like.
Well, okay, that's good. Because relation, they cannot diagnose obstruction because you don't know what's closing out. It could be sphincters. It could be pelvic muscles. So you can't. So I think the pressure and flow must be taken together for the diagnosis of obstruction. Now, there's only one thing that actually concerns me is the pressure that is recorded. Is it a genuine technical pressure? Because if you look at the subtraction, it is not 100% accurate. Isn't it? I mean, look at his problem before that. There is some amount of there's some amount of leakage of pressure, and that is why such a high. That is why such a high interval pressure. There could be some amount of slip of the system. So this is not entirely a reclusive contraction. You have to suspect, you have to doubt it. Okay. There is a thing called myogenic reclusive failure, which is seen less commonly, but in the patients of posterior valves. And they have abnormal reclusive to start with because the abnormality begins in utero, and therefore myogenic failure is one phenomenon which we must understand and keep in mind. So then the bladders fail to contract completely. But it occurs in a later stage, at the age of 19-20. It doesn't occur in very early childhood. It takes its toll, it comes in later. A myogenic reclusive failure is well-known phenomenon in posterior valve children. Okay, and then this could be one of that. But certainly this voluntary contract, even if it is poorly sustained. Okay, so let's finish in a minute. What's the plan of action now? What would you say?
Yeah. So what do you think is the plan of action now? What should we do?
I mean, you're asking me.
No, I'm saying.
You are.
We should first take up the patient for cystoscopy, cystoscopy. We could look for any residual valve. These having obstruction, obstructive, suggestive of obstruction.
Well, I have to address so many questions. Number one, does he have outlet obstruction at first? Number one. Number two, does he have reclusive failure? And what is the genesis of upward tract dilatation and CKD in this case? The three questions you have to answer.
The first one it is that as the curious about low and high reclusive pressure, and they're highly indicative of obstruction, bladder outlet obstruction, and the parietal upper urinary tract dilatation and CKD are also on the account of bladder outlet obstruction.
So, what will you do with MCU help?
that we should first plan him for cystouroscopy, sir, to look for any obstructions or residual PUV, posterior residual valve, sir.
Yeah, I agree. He has undergone a fistula cause. He could have a rigid prosthetic urethra. He could have a punctured obstruction. He could have a bladder neck obstruction. Bladder neck hypertrophy is very common in this. So one of those things, I think he did a good endoscopic evaluation. Okay, that's number one. What is the cause of CKD in this case?
The back pressure changes on the account of chronic bladder outlet obstruction, sir, leading to bilateral hydrouretic necrosis.
It's a compliant, very hyper compliant reclusion.
So, but it is obstructive, no? It is obstructive.
Yeah,
So the obstructive uropathy you want to say.
Yes, sir, obstructive
but
uropathy.
there has to be a mechanism by which kidneys are damaged.
The bilateral valve is the compliant blood.
Prosthetic hyperplasia does not cause kidney damage in every case. It can be very rarely actually.
The bilateral
Chronic retention causing this.
Chronic retention, what's the mechanism of chronic retention causing upper tract damage? They used to have reflux, used to have sepsis, or you used to have poorly compliant bladder, or severe degree of overactivity. And he has none of these actually.
Whereas there are bilateral hydrouretic necrosis on the sonography, so there can be chances of bilateral reflux in this patient.
Pressure might be transmitted. Obstruction itself will cause obstructive.
Hey, but what's the mechanism? Obstruction will mean high pressure. When you're keeping high pressure only for a few seconds or a few minutes, but rest of the time his bladder is compliant and keeping low pressure all the time. Isn't it? So you have to explain the mechanism. Obstruction can cause, but the mechanism should be through poor compliance, through overactivity, through small capacity, or through reflux.
Filling pressure throughout the period is stable there.
Right.
So this pressure causing lateral necrosis is probably less likely.
Yeah.
As while voiding also, it is not going that high.
54.
I'm trying to go here.
The MCU can be done.
That is again not a sustained kind of adhesion. So pressure is not causing it. So probably reflux is. So POV reflux is the one of the common thing that. So probably reflux is there. Right. Any last kind of comments on this question? Yes. What next we want to do? Last minute.
Yeah.
Find out. Okay.
See, we have not found the file in the book like some the MCU can be done, can we do an MCU? MCU is not voiding. So very there is no end to check for there is no end, no quantity to MCU. To check for
The reflex can be.
yeah, you can say reverse. He could have reflux during filling phase as possible.
When oil is
No pressure.
low pressure reflux.
Frequency volume chart. I need to find out how much volume is starting in the night and in the day. We have to pull out interstitial lymph like this. We have to pull out any area.
And also see the post-void residual product. All right, I think. Anything else?
The residual volume is 840.
840 residual volume. So almost is then.
So FT was the 940.
So we had a quiz, Urodynamics quiz. So the questions were, I think, quite
Simple, not simple, very simple. So that's why we had tie amongst 5 of them. So out of 15, 11, 5 had a same result, 11 marks. 11 marks.
Correct answers.
Correct answers. 11. So they all scored 11, 5 of them. So out of these 5, so 5 of them were Dr. Ayush Mittal, Dr. Somit, and Dr. Prajjot. Just please stand up. Dr. Ayush. Yes. Good. He was answering also many questions. Dr. Somit. Yes. Dr. Prajjot. All 3 from SP Medical College, Bikaner. Okay. And 2 from our college, Dr. Rajesh Kumar. Yes. And Dr. Pankaj. So 5 of them were 11 and the rest were 10, is it? 10 and 9. 10 and 9. So we have 3 awards. So what we did, 2 of our medical college students, they have voluntarily said that we would not take slots. Yes. So we will give these 3 awards to these SP Medical College residents, and how to give first, second, and third. So what we have done is 3 checks. So madam will take out and just find out who is the first, second, third. So you have number 1 also written name it. So first, this is first. I used to get the first, right? Yeah. So we will have a photograph also together, all faculty first and then all after. Dr. Somin. Yes. Thank you. So we'll have some concluding remarks from Dr. Sujata, Dr. Suresh. So I thank all of you. I also expect to have your feedback also. You can just give them some email and answer discussion का time नहीं. Answer discussion में time नहीं है, वो बाद में करेंगे. और feedback के लिए एक email address दे देना मेरा या किसी का. So then we will send their feedback. Anybody has any feedback and you want to just say something here, please you can come. And Madam, what's
I'm definitely very obliged and thankful that Dr. Shiva just decided to do this program at such a short notice, and we had such an overwhelming response. Obviously, it is all hard work on him and the department and all the students and faculty here, and we are extremely thankful to Dr. Yanjay to come and travel and take all the trouble to travel and come here and teach us, and also to Dr. Dhawan, to Dr. Devendra, and to Dr. Maniraj and Chaudhary, and Dr. Mukesh also to come here. So definitely, and please give your feedbacks. And when would you like another program on a similar topic, but in a different part of the state? Definitely, we can do this. And apart from heartfelt thanks, I think I have nothing more to say. And it was really very well organized, and this was something new which came up. And I wish we had time to discuss the cases, but maybe some other day.
But still we could manage a lot of it.
Right, thank you. I'm thrilled to see such an exponential response from the students. And I think the main credit goes to the inspirational activities of Shivana.
Dr. Mukesh, Dr. Mani, and Dr. Vegan.
I'm quite thrilled to see the spontaneous response so much. And I will hope that we are going to your satisfaction. We would like to hear feedback from you. But what I feel is this is a learning process, learning experience for all of us, for you as well as for us. From that point of view, I'm extremely grateful for USI ISC to give us this opportunity. Traveling has never been a problem. I think traveling to Jaipur was always a pleasure. I must have done 5 or 6 trips to Jaipur so far. And this is the most satisfying trip. So thank you, everybody. Thanks a lot. And we will remember this trip for a long time.
Faculty, पहले आपको पहले एक ग्रुप फोटोग्राफ ले लेते हैं. So I once again thank